As we work through chapter 20, we're talking about our cholinergic drugs. Now, out of chapter 20 and 21, chapter 21 is more important. But if you understand chapter 20, then you'll know that almost the flip side is what's true in chapter 21. So when we're talking about cholinergic drugs, in our textbook, we're really talking about acetylcholine and what happens when our parasympathetic nervous system is innervated, or when that is specifically working. Your book goes into a little bit about how we have two different types of receptors for those cholinergic receptors, either a muscarinic or a nicotinic. We want our drugs to be at such a level that we innervate the muscarinic receptors. If the drugs are taken at too high of a level or too high of a dose, we tend to innervate the nicotinic receptors, which has some more negative effects associated with it. Again, when we are thinking about these the cholinergic drugs, I want you to think about that parasympathetic nervous system. We'll come back to this one in just a second. So when we're looking at our cholinergic drugs, they're going to mimic acetylcholine, so the effects of acetylcholine. So keep that in mind. They can work either directly by binding or making those receptors activate, or they can work indirectly where when I have a cholinesterase inhibitor. When I have that, that's what keeps that cholinesterase from breaking down that ACH, which would mean I would have more acetylcholine available for the receptors to take up. We can also have, within that indirect, we can have reversible and inversible actions. Reversible means that those medications are going to bind to that cholinesterase for just a short amount of time, and the irreversible means it's going to bind for a longer period of time, and I usually have to make more of that cholinesterase to break the bond. So just a little bit of background on that. When we're looking at all of our cholinergic drugs and we talk about the action and the drug effects that we see, again, think about we're stimulating that parasympathetic nervous system. If you forget what happens when we stimulate that, go down here to the rest and digest. So chapter 21 is going to do with the sympathetic nervous system, fight or flight, but chapter 20 with the cholinergic, we're thinking about that parasympathetic, where we talk about the rest and digest system. So that's what we want to consider. When we take those cholinergic drugs, here are the things we're going to see. We're going to see increased gastric secretions and increased gastric motility. So think about moving stuff through that GI tract more aggressively. We're going to have an increase in that urinary frequency. We're going to have that meiosis or constriction of the pupils. We're going to have that reduction of intraocular pressure. This is probably one of the only times we'll think about glaucoma and a medication not being contraindicated, because we want to decrease that pressure. And then it's also going to increase salivation and sweating. For the cardiovascular system, it can cause a decrease in heart rate and vasodilation, as well as in the respiratory system, it can cause bronchoconstriction and narrowed airways. Again, this is when I take those medications at the dosage that innervates that muscarinic receptors, not the nicotinic. If I innervate those nicotinic receptors, I've taken more than that usual the desired effect. So it's I always think about it as taking too much of it. So I've taken so much that it's not only done the muscarinic receptor stimulation, but it's overdone it by giving me some adverse effects because I've innervated that nicotinic receptor stimulation. If you have problems understanding that, if you'll look on page 317 in our text, there's a, let me pull this over. There's a nice table here, as well as these two paragraphs that explain what I just said. And if I'm taking the medication, those cholinergic drugs, as ordered, then we tend to see these effects. That's what we are wanting to see. If I overtake it, so if I'm taking too much of that, then I'm going to get undesirable adverse effects, which are these over here. So this slide kind of wraps that up too. So page 317 is where we define that. So if I can understand that, let's see if we can answer this question, because this is right what's next in our textbook. When we talk about a patient that's been taking a cholinergic drug, so think about what it's doing, and then they have flushed skin, orthostatic blood pressure changes, and abdominal cramps and nausea, what are they likely experiencing? And on this, our answer is an early signs of cholinergic crisis. Again, let me pull us back over to our textbook here. So when we're looking at cholinergic crisis, that's when I'm working on an overdose of a cholinergic drug. So I've taken too much of it, and we see those symptoms are those circulatory collapse, that hypotension. I can have bloody diarrhea, shock, and arrest. Early signs, so we'd want to catch it in those early signs when they have abdominal cramps, salivation, flushing, nausea, and vomiting. So if we can catch it early enough, we can prevent this later circulatory collapse from occurring. So trying to catch that early would be important with them. Here are some of those different adverse effects that we see with our individuals. Again, once we've taken too much of that medication and higher doses than that patient needs, that's when we'll see these. So you're asking, why would we take our cholinergic drugs? It has these negative side effects. Well, we might use them to reduce that intraocular pressure. So think about patients that do have glaucoma, or they're going for intraocular surgery. Those would be a big one. We also might take it with individuals who have problems with their bladder. So with our medication here, uricoline, we might take the uricoline because it's going to help that bladder tone and motility. It's going to allow that bladder to empty well and empty fully and not hold on to urine. And that might be very common after surgery to help with that atony, where the bladder has lost its sphincter control and it's holding on to urine too much. Not lost sphincter control, excuse me, just the opposite. It's holding on to urine. It's not able to micturnate or urinate and get rid of that urine. So it might be useful in that situation. Some further indications of our cholinergic drugs are individuals that have if they have myasthenia gravis, we could use it for that, or to reverse neuromuscular blocking drugs. So think back about our anesthetics that we might have used for neuromuscular blocking. They can also reverse our anticholinergic medications, which we'll talk about next in our chapter 21. Some other examples, we can use it in mild to moderate Alzheimer's disease, especially this Aricept and Namenda. You'll see these two utilized in the hospital setting quite frequently, and we'll talk about both of these in just a minute. Aricept is a cholinergic drug, and Namenda isn't a cholinergic drug, but it mimics the function, so we can use that for our Alzheimer's patients. Lots of contraindications for our cholinergic drugs. Obviously, those drug allergies. GI or a GU obstruction. Now think about that. Does it make sense that if I have problems emptying my bladder that I would not want to give a cholinergic drug because it would put too much pressure on that bladder? Also in patients with bradycardia, because I'm in the rest and digest stage, so my heart rate is automatically lower, so it would further compound it if I gave it to somebody with bradycardia. Epilepsy, hypotension, chronic obstructive pulmonary disease there because of that constriction effect. Some more adverse effects that we see there, and these think about the overstimulation of that PNS. So I've overstimulated that rest and digest. So cardiovascularly, I'm going to see those things that go along with overstimulating that cardiovascular rest and digest phase, all the way down to cardiac arrest. Central nervous system, think about I've given too much of it, so same things. I'm going to see that headache and dizziness. GI, we're going to see those abdominal cramps, nausea, and vomiting. Again, these are the adverse effects that are associated with that. In my adverse effects for respiratory, we can have increased bronchial secretions and bronchospasms, which would make it difficult to breathe. And then lacrimation, so that tearing, T-A-R-I-N-G, tearing of the eyes, sweating, salivation, and that meiosis also can occur. Do keep this in mind. We've mentioned this sludge before when we were talking about our Parkinson's patients. So if you think about when we're managing a patient in a cholinergic crisis, one of the things we might see is sludge, which is that salivation, lacrimation, urinary incontinence, diarrhea, GI cramps, and emesis. These are early signs of that cholinergic crisis. When we treat them in that early phase, we're actually going to give a cholinergic antagonist, atropine. We'll talk about this in great detail. And then we're going to, in severe cardiovascular problems, we're going to treat it to open up this bronchoconstriction. So we're going to look at bronchodilators to open that up specifically. Some of our interactions with our cholinergic drugs are anticholinergics, which we'll talk about in the next chapter. Antihistamines, think about Benadryl, would impact with Benadryl causing excessive sleepiness. And then it can have, if I add them together, say I'm taking multiple cholinergic drugs, they can have additive effects. So they're working exponentially to create too much of whatever we're trying to do with them. We're going to look at 3 drugs specifically. This first one is this uricoline. So on this one, it's a cholinergic agonist, so it's a cholinergic drug. We use this specifically to treat that postpartum and postoperative urinary retention that's caused by no obstruction. So it's usually that bladder is just asleep. It hasn't woken up yet. So we'll use it to treat that. Some contraindications are hyperthyroidism, drug allergies, and then cardiac problems, which we've mentioned. Adverse effects that could occur with uricoline are that syncope and hypotension, and then making sure we're monitoring about taking acetylcholinesterase inhibitors. So watching for that. My next drug of choice is my Aricept. So my Aricept is my Alzheimer's patient treatment. We use this in our mild to moderate Alzheimer's disease. Again, contraindicated with drug allergies, lots of adverse effects that we've seen with everything else so far. So still looking at those, including bradycardia, syncope, hypotension. Think about these things in relation to falls with our patients with Alzheimer's disease. And then the last drug in this section is the Namenda, which is not a cholinergic drug, but it does a lot of the same things as our cholinergic medications, which is why it's here. Very similar with our adverse effects that we see with that medication. We've mentioned this a few times, but we want to make sure we're asking our patients about over-the-counter and herbal medications. Ginkgo is one of the ones that will interact with our cholinergic medications. So an individual might be on Ginkgo over-the-counter to help with vertigo or memory loss or tinnitus. Ginkgo can cause that GI upset and headache and can interact with aspirin, anticoagulants, and convulsants. And there's a good question for us here. A 60-year-old woman. She's taken Ginkgo to help with her memory. She has a history of Alzheimer's, type 2 diabetes, thyroid. She's currently taking NSAIDs for arthritis. What potential adverse effect could that should we be aware of with that Ginkgo? And our answer is C there, which was that bleeding association. So that bleeding tendency with that individual. At the end of the chapter, do read through those nursing implications, especially the assessment, the intervention, and the evaluation for those cholinergic drugs. Again, we won't see these used as aggressively or as familiar as the medications that we'll have in chapter 21, but if we understand the parasympathetic nervous system innervation with these, then that'll set us up for success in chapter 21.